Hi, everyone. Thanks so much for joining us for the Minogue Medical's Robot-Assisted Colorectal Surgery Symposium. The symposium will just be introduced by myself. Our main presenter is Dr. Julio Garcia-Aguilar, and then following his talk, we'll have 2 additional speakers and then a subsequent panel discussion by my colleague, Dr. Marilis Boutros. So, as all of you know, minimally invasive surgery really is dominating most parts of our general surgery landscape, and most of the field has really converted to minimally invasive approach. And it's been shown that robotic assistance for certain surgeries can help decrease the likelihood of converting to an open procedure. And when we look at robotic assisted surgery, its use is really accelerating worldwide in many realms. And a lot of us would think of urology as being the main driver of that, but it's evident when we look at the data that both gynecologic surgery and general surgery, including colorectal surgery, is really accelerating extremely rapidly, and that acceleration is outpacing urology by quite a bit now. Adoption in Canada really has been slower than I would have expected, but probably for many reasons, including the fact that some of the newer technology hasn't been available in Canada until more recent years. But we do have colorectal robotic groups across the country now, and certainly lots of other groups that are considering moving forward with robotic surgery. We all know, or we've all heard about some of the pros and cons. I'm no robotic expert, so we're going to hear from the real experts shortly. But the potential benefits we hear about are the multiple degrees of freedom that you have with the instruments and ability to be extremely precise. You have 3D vision, you've got greater ergonomics, and potentially much better access to deep, difficult pelvises, particularly in the obese patient. Potential disadvantages that people have talked about are the lack of haptic feedback, the potential cost, particularly in setup and startup, at least initially longer setup and procedure times, and then what can be a significant learning curve in some situations. Certainly the use in our field has been predominantly discussed in the realm of rectal cancer surgery and accessing sort of deep pelvic dissection, but there's certainly an expanding role in other pelvic procedures, including IBD and benign disease. And there's certainly lots more talk now about using robotic technology for a lot of abdominal surgery. Certainly as we expand all these areas out, particularly in a healthcare system such as ours, we have to always balance the patient benefits against the potential for increased time and costs, even though it may be that the costs aren't an issue when we look at the whole greater overall cost of care, as we'll hear, I'm sure, from some of our discussants. So really, we've brought together some great people with some experience to help us sort of learn a little bit about robotic surgery, particularly in the colorectal realm, how we can sort of think about it and potentially look to incorporate it into our own practices. The 3 panelists that we have are Dr. Julio Garcia-Aguilar, Dr. Haili Wang, and Dr. Antonio Caycedo. Dr. Garcia-Aguilar is going to be our main presenter today, and he's really one of the main pioneers of robotic colorectal surgery. As I'm sure everyone in the audience knows, he's the chief of colorectal surgery at Memorial Sloan Kettering, and he's really been instrumental in driving many research endeavors in the field of rectal cancer and colorectal cancer. And I'm really excited to hear his talk on his experience with robotic colorectal surgery. Thanks, Dr. Garcia-Aguilar. We'll switch to his slides, please.
Okay, yeah, let me share my screen. I think you need to stop sharing so I can share the screen. Well, first of all, thank you for inviting me to participate in this symposium. I'm going to move to my first slide. Well, again, thank you for inviting me to participate. These are my disclosures. And well, I was fortunate to start working in a place like Memorial who invested early in robotics. As you can see, they started right in 2001, 2002, and probably that was on the hand of the urologists. But then in the last few years, every service very much, for the most part, has been using robotic at MSK. We started with some standard equipment, and now we are up to 9 XI platforms. We use robotics almost in every service for a number of procedures from gynecology, urology, colorectal probably are the top user, but we have also thoracic, gastric, and mixed tumor. They do gastrectomies, even some head and neck, and now even liver surgeons. So we all use the equipment. When it comes to colorectal, we have done already over 4,000 procedures. The institution as a whole has done more than 25,000. And these are the numbers in the last few quarters. We started almost exclusively with rectal procedures, and now we are doing mostly colon and rectums. Rectal cancer surgery has gone down with the adoption of watch and wait, but the colon cancer surgery is still very strong. And I started when I was at UCSF back in 2006, 2007. I started with the standard platform. When the first time I saw it, I thought that technology had a future. And I have used all of the equipment from the standard to the S, to the SI, and more recently to the XI. I think the technology has evolved significantly from when we started in the 2006, 2007 years to now. We have table motion, we have staplers, we have vessel sealers, equipment that we didn't have at the beginning. And that's the reason why probably now it has been adopted in many more sites and by many more specialists, because we have an array of instruments that help with the procedures quite significantly. Now, I think you're going to build a robotic program. I think there are a number of principles. You have to understand that this robotic platform is only a tool. And it's a tool to be incorporated into the minimally invasive surgery. I think, as you mentioned, improved dexterity, visualization compared to conventional laparoscopy, but needs institutional support. I think just using it as a market tool is the wrong focus for developing a program. You need to have access to platform. You cannot develop a program if you only can access the equipment once a month. And you should have some high volume, like with everything else. I think you need to develop it as a kind of as a team. It's important to start with a key surgeon who is going to be the one leading the group. And you can just use somebody in the house that gets trained and slowly progresses through the experience, or you can bring somebody from the outside. But you have to accept that there's going to be a learning curve. I think it's important to avoid having too many people starting at the same time. It's better just having somebody leading the experience, and then bringing other people on as you gain experience. In our institution, the robot belongs to all the surgeons, to all the specialties. We don't have any block ownership. Again, we always have the impression that the robot is a tool that is used whenever you need it, in whatever specialty. Again, it's very important to build teams in the operating room. I think you have to have key personnel in the anesthesia department and also in the OR staff. At the MSK, we are fortunate to have designated PAs that they are at the bedside. And because they are there all the time, they have tremendous experience setting and doing everything that has to do with the equipment at the patient side. That also allows us to train the fellows in a dual console. I think that's one of the advantages of the robot. It's also very important to track all your cases and your experience closely, particularly when it comes to problems and complications. I think it's important to have a plan for credentialing and safety. I think also because the technology keeps on changing, there has to be somebody who's going to be paying attention at technology and innovation and decide what is going to work for you and what's not. You have to have also a program of training and education, particularly if you work at an academic institution. And also the issue of utilization and efficiency. You have to standardize as much as possible so you don't waste uses of equipment just for small portions of the procedure. I think you have to have oversight of the product evaluation and acquisition. And again, if you are like us, an institution that has more than one campus, you have to integrate the process across all these multiple sites. In our institution, we have a big program that a program on minimal invasive, and robotics is a big part of that. We have a director and we have multiple representatives of all the groups, surgeons, nurses, techs, administration, schedulers, and they address all the issues related to the points that I made before: credentialing, education, product acquisition, etc. It's important to have a program that is going to take care of all these issues. I mean, I think these are kind of 10 tips for success before I get into more detail. I think you have to be convinced that the robot is going to be used in your practice. I mean, if you are not convinced and you are going to just start in a kind of, not very positive way, probably you're not going to go too far. You have to convince the institution that at the end of the day, the robot is going to be used in your practice. Again, you have to build a team. It is very important to have the anesthesiologists or nurses and bedside assistant with you. You have to have backup, sometimes from other specialties, if they have more experience. I think it's key not to start with complex patients or with complex cases. I think you have to set realistic goals when you start. And sometimes you might only perform a portion of the procedure robotically, and then, expand the extent of the operation as you become more familiar. For example, when we started doing robotic surgery, we use it exclusively to do the pelvic dissection. And then with time, as the equipment evolved, we were able to do the colectomies and do the mobilization of the colon. But I think the equipment that we had when we started were not conducive to that. So I think you have to be smart about it. If you can, the XI platform is better because it has a number of features that make it easier to use and more versatile than the previous forms. And then one big advance was the development of the table motion. One of the disadvantages initially with robotics compared to laparoscopy was the inability to use gravity to the full advantage as you can do with laparoscopy. And I think that was something that was solved with, they were able to introduce table motion, because gravity is going to be important for exposure. So I think in summary, from this part, I will say that the XI platform is a tool that facilitates minimal invasive surgery. And I think, as I mentioned, the development of a robotic program required an effort from everyone and support from the administration. You have to have a plan that you're going to be able to implement. I think the issue of the volume is important. I don't think that you can develop any minimal invasive robotic or otherwise program if you are doing a case, here and there. I think you need to have a volume, and you have to dedicate the time and the resources. And again, you need to have an administrative program that is going to address all these other issues that I mentioned before. So why the Da Vinci in colorectal surgery? We view it as the next generation minimal invasive surgery. I think it extends the benefits of minimal invasive because, as it has been mentioned, the issue of the lower conversion rates, and also because it facilitates the performance of intracorporeal anastomosis and optimal placement of incisions, extraction incisions. But also I think I wouldn't say improve and maintains the oncological outcomes. I think allow us to do a good TME in patients that, might be pretty difficult to do otherwise with other techniques. And also has taught us a lot about CME and central vascular ligation in colon surgery. So I'm going to talk a little bit about this aspect. So the colectomy, I will start with the colectomy, which is the procedure that we started, kind of second. We first started doing TMEs and then we moved to the colectomy. But I think there are 3 reasons why we have adopted the robotic colectomy. Conversion rates, the completeness of the mesocolic excision. I think we do the best operation that we have ever done. And then the ability of doing an intracorporeal anastomosis. So one of the problems with the laparoscopic surgery is the conversion rate. I mean, this is data from prospective trials. They are all now quite old, and probably in many surgeons, the rate will be probably half of that. But still, I would say 10–15% of the cases that they are started laparoscopically, they ended with conversion. And with conversion, you lose many of the advantages of the minimally invasive surgery. Again, there is evidence of the literature that the conversion rate is lower with robotic compared to laparoscopy. In our own practice, we have recently looked at colectomies performed laparoscopic, robotic, and open, and we found that the conversion rate was significantly lower in the robotic era. We must say that these were the same surgeons, but it was a different time period because we have evolved from open to laparoscopic and more recently to robotic. But I think that laparoscopic was just an experience in almost over 800 cases. So we can say that most people at that point had passed already the learning curve. So I think that probably is one of the main advantages. Probably we get now more lymph nodes than we used to do with the robotic platform. But also I think we have learned a lot about the complete mesocolic excision and central vascular ligation. This is the idea popularized by the group in Erlanger in Germany. It's still debatable. There is some data from Nick West, one of the pathologists at Leeds. They did an audit of their own colectomies, and they looked where the surgery was done in the proper mesocolic place, in the intramesocolic or in the muscularis, and they found that that had an impact on the long-term outcomes. The other issue, other than the mesocolic place, is the number of lymph nodes. We know that both in stage 2 and stage 3, the number of lymph nodes harvest has a prognostic implications. And again, when we look at the laparoscopic procedure, the number of lymph nodes was not as high as one would like to think. And the reason why the number of lymph nodes with laparoscopic colectomy is probably low is because laparoscopy is technically challenging. We are not used to dissect with deep rigid instruments along the big large vessel like the superior mesenteric vein and superior mesenteric artery. And that leads to an incomplete mobilization of the mesentery. A lot of people leave the more central portion of the mesentery attached to the big vessels. And then we usually don't remove the central lymph nodes. So, this is a cartoon of the lymph nodes I'm talking about, the pericolic, epicolic, intermediate, and central lymph nodes. The red one will be the D1, the blue, the D2, and the yellow, the D3. I guess that with laparoscopy, most people will do a D1, maybe a D2. Some people D2.5, as I call it, but very few people will do a D3, even if the lymph nodes are enlarged in preoperative imaging. I mean, this is a typical case, a patient of mine with I saw him for the recurrent, but it was a lymph node close to the blood vessels in the baseline imaging of 2013, had a right colectomy, and came 2 years later with those lymph nodes enlarged with a recurrent in that location. It's something that doesn't happen every day, but we see often that lymph nodes are left behind close to the origin of the vessels. And when you ask the surgeon what procedures are the most complex one in terms of vascular dissection and performance of an anastomosis, the right colectomy and the transverse colectomy are some of the procedures that the surgeons consider that they are the more difficult one. Again, the number of lymph nodes, we have looked at our own experience with the open, laparoscopic, and robotic. We obtain more lymph nodes. We cannot say that that translates into better oncological outcomes yet, but this will be the typical specimen from a patient treated with complete mesocolic excision and central vascular ligation. This will be the pedicle of the ileocolic, the middle colic, the window where the duodenum will be. View from the other sides, these are the clips in the middle colics, in the ileocolics, and those are the lymph nodes along the superior mesenteric vein. The other issue that I was mentioning was the issue of being able to perform an intracorporeal anastomosis. And that, the reason why we decided to perform intracorporeal anastomosis was because when we do extracorporeal, we tend to use a midline incision. And a midline incision has been associated with a very high hernia rate. In this series from the Cleveland Clinic, they compare the the incisional hernia rate in different type of incisions, and of course the funnel steel was the one who got the lower rate of incision. So that's the incisional hernia. So that's our preferred extraction site in most colectomies and proctectomies nowadays. We almost exclusively use the funnel steel incision because, again, it's associated with a lower hernia rate. And what has been proven is that it is easier to perform an intracorporeal anastomosis using the robot compared to using laparoscopy. It's not that you cannot do it. We used to do intracorporeal anastomosis before the robot, but I think it was a little bit more challenging. I think we have standardized it a lot now, and we do it systematically. And we just look at my own experience with a number of cases of colectomies, right colectomy with intra-extracorporeal anastomosis. One of our junior faculty looked at this experience, and we found that the outcomes were not significantly different. Probably the length of stay was a little bit shorter, but what it was shorter was the rate of hernia, as we had predicted, from our previous experience. Our hernia rate when we use the midline is close to 30%, and it's much lower when we use the funnel steel incision. This is just some technical aspects. I want to show a video, but I think probably the videos are available everywhere, and I will just be showing you how we do a complete mesocolic excision from medial to lateral. This is the way we, we'll do the operation. If we're going to do extracorporeal anastomosis, we will put the camera in the midline, and then we will enlarge that incision to stack the specimen. The instruments are in the other side. If we're going to use a funnel steel, this is the way we put the instruments, the working ports 1, 2, and 3, the assistant port, and the camera off the midline, and we will have a funnel steel incision. Again, for a D3, lymphadenectomy and a right colectomy, we will identify the ileocolics, and then we'll follow the plane along the superior mesenteric vein and artery, and then we'll move to the right branch of the middle colic, or you have to do a extended right colectomy to the middle colic, and we'll do a medial to lateral dissection, taking the entire mesocolon in the way I show you in the specimen. For the left side, we don't have it worked out as well. Doing a D3 for a left colon cancer, you have to do a very extensive resection. So I cannot do a D2.5. We get the left colic, the left branch of the middle colic, and the left colic vein. For a sigmoid colon, we will just take the inferior mesenteric artery and the inferior mesenteric vein. So that's our standard approach for colectomy using the robotic platform. So I think, in summary, the robotic platform reduces the conversion rate and extends the benefits of minimal invasive surgery in colon cancer. I think we have learned a lot, and I think now systematically we do a complete mesocolic excision with central vascular ligation, because the planes are easy to define, just working over the duodenum and the pancreas, and again, I suppose what some people can think, the blood loss is minimal, and we get the good result. And then we use the robot platform with the Surform stapler to perform intracorporeal anastomosis, and we close the common enterotomy with stitches. We perform a side to side with the robot in the right side coming from the left upper quadrant trocar. There we put our 12 millimeter, and then we do an isoperistaltic side to side ileocolic anastomosis. That allows us to extract the specimen through a funnel steel and reduce the risk of hernia. Now, what about robotic TME? I think the benefits of doing, laparoscopic versus open TME are clear in terms of faster recovery, all the short-term outcomes. It sounds like the long-term outcomes are also similar. Conversion rates are not trivial, even in the hands of the experts. And I think the problem is that we don't always operate patients like this. We have sometimes patients like this. And in those patients, laparoscopy is problematic. And that's the reason why even in the United States, I think probably less than 50% of the patients had rectal cancer surgery done laparoscopically. I think it's, laparoscopic TME is technically challenging. That's the reason why I personally jumped into robotic very early on, because I had difficulty working with the long, rigid, non-articulated instruments in the pelvis. And when I saw the first iteration of the robot, I thought that it was a tool that it will improve the minimal invasive surgeries in that area. Of course, ergonomics, I'm going to talk about that to surgeons. And the only thing is that, also in laparoscopy, you need very expert assistant. In robotic, you don't need so much assistant, you don't need a camera, you control many more instruments. And I think these are the advantages that they have been mentioned already. Stable platform, articulating instruments, more surgeon control, you control the camera, you control 3 arms, ergonomics, and of course now we have a stapling that allow us to do that. I was going to show a case, but I'm just going to move fast because I think the videos are probably not very informative. For the robotic TME, again, we started using the robot only for the pelvis, and we did the mobilization of the colon laparoscopically, and then we used the robotic platform just for the pelvic dissection. So we kind of started doing this dual dock when we went into the robotics. We used to dock first from the right to the left to do the mobilization of the colon, control the inferior mesenteric vein, the inferior mesenteric artery, go medial to lateral, get over the pancreas into the lesser sac, detach the left side of the omentum from the transverse colon and mobilize completely the splenic flexure. Then we undock, put the patient in a different position, put the patient in steep Trendelenburg, rotate the boom of the robot, and then have the instrument facing the pelvis. The company has a different idea. They want to put the instrument in a line, and it worked for many people, but in our case, we persist using the same approach that we did laparoscopically, or with the S or with the SI. And it works with us because you have minimal collision with the instrument and you have great exposure in the pelvis, great use of the instruments. I personally use the camera a little bit of the midline to the right. My scissors are in a trocar in the right lower quadrant, and I have 2 instruments in the left lower quadrant. The more medial one is my bipolar, and the far left is whatever instrument you prefer, just to retract anteriorly, particularly when you are going to do a very low dissection and you need some dissection anteriorly. This is our approach. The trocars for the first part of the procedure are in the right side. With these 2 instruments, we're going to work this way. That's the assistant and the camera. And then we're going to change and we're going to work with this instrument down in the pelvis. I think we have some illustrations of how we do it. So the first part of the operation with the patient left side down, right side down, and some Trendelenburg. We work on the left, mobilize completely the colon from the midline to the pelvis. And then we change the boom and focus on the rectum, putting the patient in a stripped Trendelenburg and without lateral tilt, just focusing down into the pelvis. That's the way we do it. Well, I think I have a video here. This is a patient, the patient I was presenting before. I cut the inferior mesenteric vein, go from medial to lateral. This is a little bit fast, taking the attachments of the splenic flexor from the medial side. We have got to the left, you can see I got already into the lesser sac, watching the stomach, and just taking the last attachments of the splenic flexor, now removing the omentum from the colon. And here's some attachments of the root of the mesentery of the colon to the back of the stomach to have full mobilization. All right, once we have done this, we take the artery, we'll show you in a minute, trying to open the mesentery as much as possible to make sure the bowel is going to reach. We cut the inferior mesenteric artery at the origin. And then once we have done this part, we just go to the pelvis. Now we are behind the mesorectum, starting at the level of the promontory, and then I use scissors almost exclusively. And with 2 instruments, and with just some suction from the assistant, essentially you can do the entire procedure with pretty good visualization and control. This patient has received total neoadjuvant therapy, and they have a complete response, and we just did a mesorectal excision. I think I want to see if I can make it fast. I go posteriorly as far as I can, and then I go laterally, and then I go posteriorly again, and then I go laterally, and then I go anteriorly. We always work around and around, staying in the mesorectal plane. And you can see just need minimal assistance from your bedside help. So in the right side, just to retract some time, and then just for suction and smoke evacuation. But I think the steadity and the visualization and the control is something that for me is difficult to replicate laparoscopically. I was never able to do it. And I know that there are some pretty good laparoscopies, but I think you have to be really, really skillful to get this type of control. Yeah, the planes are, usually very well defined. And, you just see, I have my left lateral arm holding in the front. In this case, I'm now getting behind the seminal vesicles, and that instrument is very useful. You don't need to have the usual hard instrument that we used to use in open surgery, and accomplishing much more, and the visualization is better. So I think you get an idea of how this thing works. We can go fast. We are now behind the prostate, going all the way down to the lower part. In this case, it was a complete mesorectal excision. Now, for tumor-specific mesorectal excision, I think these instruments are even better, because the instrument that we use to devise the mesentery, the mesorectum, the vessel sealer, articulates, as opposed to the instrument that you use in laparoscopy that they don't. So you can come at a right angle when you are going to transect the mesorectum, and just facilitates not coning, as we used to say, in the mesorectum, to make sure that you divide it at 90 degrees. Now this is the robot. We always come from the front. Pretty rarely we are able to divide it in one file. Sometimes we have to use two. But you have done good mobilization and selected the cases well. It works quite well. So again, this type of visualization, I guess, is unusual to have it even when you are doing the surgery open. We use the ICG, we use the visualization of the anastomosis, and do the Ehrlich test with water in the pelvis. So that gives you an idea of how we use the robotic for a TME surgery. Now, conversion rate seems to be lower in the retrospective case series and also in the roller trial. Even though the roller trial failed because I think it was underpowered, they estimated that the conversion rates were going to be much higher than 12% in the control arm. So what happened is that both the control arm and the robotic were lower than anticipated. So the study kind of was negative because the odds ratio, crossed 1. For males, it was a intended analysis, but it was not the primary endpoint. It was somewhat lower. I mean, there are problems with the roller trial. I think it has been discussed extensively. Again, it was negative, but I think the fact that the conversion rate was significantly lower than it was originally anticipated in both arms was probably responsible for that. In our own institution, we don't have much laparoscopic experience in terms of TME. We have recently compared our outcomes in open and robotic. Of course, these are difficult comparisons. They are retrospective. The only thing that we learn is the conversion rate is very low. Complication rate, they seem to be lower with robotic. Again, this is compared to open surgery, so it's not surprising. Less infection, lower length of stay, and readmission rate. Oncologically, not dramatically different. The quality of the mesorectum is 96%. Lymph node harvest, some more, we knew that. Circumferential resection margin was low in both cases. So I wouldn't say that oncologically we had a significant difference. We look at local recurrence exactly the same than open, and survival also the same. This is all retrospective data, and there are problems because we have changed many things in the time that we have made the transition from open to robotic. We have programs for surgical site infection reduction that may account for some of the differences that we encountered. Also, the enhanced recovery program is more common now than it used to be. We have changed neoadjuvant therapy. We operate less rectal cancer patients. So some of the cancer with better prognosis now, we don't operate on them. So that we have had some impact favoring probably the open group. But again, these are the problems that we encounter when we just compare retrospective data. An interesting study from the ACS, the NSQIP. Patients treated 2016, 2017, and again treated with laparoscopic or robotic prostatectomy. The only difference was in conversion, very similar to what we have reported. The operation robotically took longer, not dramatically longer, but took longer. And the length of stay slightly lower, all other parameters the same. These are two minimal invasive techniques. In our case, we were comparing open with minimal invasive. So I guess that if you can do the operation minimal invasive, probably the results are going to be better. If you are good enough to do it laparoscopically, it's not going to be dramatically different. Maybe the main gain is going to be the conversion rate. So I think in summary, when it comes to rectal cancer, as I go back to the picture of the two males that I presented there, the degree of difficulty is variable. I think easy cases are easy using whatever technique you want, and difficult cases are difficult. Having said that, probably robotic might help with the more difficult cases. I think you have to, just choose your technique carefully. In our hands, we prefer the robotic based on our expertise in the volume and the resources that we have available. And I think embracing new technology requires a thoughtful decision and a systematic institutional approach. I think you just need to think about it, be convinced that what you're going to do is going to work, and then just have the institutional support. Again, you need to have a team approach, proper training, and volume. It's possible that it might add costs. It's very difficult to tell, do a good cost analysis because there are so many variables that you have to take into consideration. But I think it's important also to understand that, robotic is not going to make you an expert in, colorectal surgery overnight. We have looked at our own learning curve. What we learned is that for the first surgeon to reach competence, it took probably 74 plus cases. Now, after that, every surgeon that came after the first one or two, it didn't take that long for what I was saying. I think, somebody, goes through the project, get to work out all the, difficulties and all the potential problems. And then that expertise, you can pass it very easily. I think I tell our fellows that, now the learning curve is much lower because we are teaching them, every trick that we have learned over the last 20 years. And also because there are other tools available that they were not available then, such as the simulator. I think the simulators allow them to know that the machine and some of the basic of how the arm moves and how they work, and that's very critical when they come to the operating room. They have spent a number of hours in the machine, so the learning curve probably is much lower than it used to be. So I think the take-home message from my point of view, I think the robot is a tool that facilitates minimal invasive surgery. As I say, probably both in colon and rectum. It has some advantages because it reduces the conversion rate. I think in the difficult cases it's useful, allow us to do intracorporeal anastomosis almost in every patient now. But again, the development of robotic program required, a coordinated effort between the administration and the physician. You have to have a plan. You need to have a volume. You just cannot be, this procedure doing, one in a blue moon. And I think you need to put time and resources to be successful. Thank you.
Thank you very much, Dr. Garcia-Aguilar. That was extremely comprehensive, but also very practical for those of us thinking to start a program. It was a lot of good hints. I really appreciate it. I was wondering, because you train fellows all the time, and now you answered my question about the learning curve. We have fellows as well. And so what do you recommend we do with them while we're in the training curve, the learning curve? So how do I manage them?
Well, I think the simulator is a great tool because, you're going to learn how to move the arms, how to move the instrument, how to clutch, how to move the camera, how to coordinate your hands. I cannot emphasize how important that is. I think the fellow needs to spend a lot of time. I mean, simulators are now available not only in robotic surgery, in many other areas. I think it doesn't make any sense in this day and age that somebody's going to come how to tie knots in the operating room. People should come to the operating room with these basic skills already learned. And I think the simulator is great for that. Now, we are also very fortunate because every one of our units has a dual console. So, it's very easy to teach because I demonstrate people how I'm doing things and then I let them do it. And if they are not doing the right movements, I can take the instrument back and give them back to them. So I think it's very conducive. Because now, when I'm doing when you do the operation often and you know exactly what you're going to do with that hand in that portion of the procedure, I can demonstrate to the fellow who is sitting in my side, you have to do this movement with this hand and this other hand is going to do that. And if they get the skills that they have got in the simulator, then they can do that relatively easy in the robot, in the operating room. So I think it's a great tool to teach surgery, and also the visualization is so good. Everyone can see the same in the room. So I think it's a good tool to teach, and I think spend a lot of time in the simulator and then just see what the other people are doing.
Thank you for the advice, because I worry about them when we are in our learning curve. You mentioned about administrative support. I so believe, like, every thing we introduce, that we have to be a team approach and have a thoughtful approach to it. I worry that we may not have as much administrative support. Can you enlighten us a little bit more about the kinds of things that administration does to support, other than, of course, okay the program and finance it?
Yeah, I mean, I think we are I'm in a privileged position. I started doing robotics when I was at UCSF, and we didn't have much in terms of administrative support. And the institution at that time, I'm talking about 2006, 2007, we had one unit and it was standard platform. I don't think that robotics was big on the radar screen at the time. So we didn't have enough equipment, we didn't have access, we didn't have people dedicated for that. So I think you need to have the institution be convinced, as I say. The surgeon has to be convinced that this is going to be useful for him or for her, and the administration needs to be understanding that it's going to be useful beyond marketing, and probably not intangible financial benefit immediately. But I think they need to understand that it's important, because I don't know where the future is going. I have no idea. It's difficult to predict the future, but I think these tools are here to stay. And I think users need to convince them. And then they need to, like I say, they have to help you build a program. They have to, support the anesthesiology, support the techs in the OR. In our case, we are fortunate that we have PAs dedicated to help in the operating room. You need to have that continuity. Somebody who really knows the ins and outs of the equipment, and they can, when there is any glitches or any problems, they know how to troubleshoot. That is very important, and the administration needs to support that. So I think it's very important that they buy in and they provide support at all levels, from the buying of the equipment to the just providing the environment that is going to be conducive to the program and the success.
Mm-hmm. Thank you very much. I really thank you for your presentation and for all the experience you're sharing with us. And I'd like to really encourage the audience to please send over your questions in the chat. We have some real experts here who can answer questions. Without further ado, I'd like my colleagues and friends, Dr. Caycedo and Dr. Wang, to go on ahead with their presentations. If you don't mind to put up their slides, please, IT.
I think those are the slides for Dr. Wang.
Sorry, can you guys hear me okay?
Yes, thank you.
Okay, sorry. Those were not my slides.
They switched them now. I think you got to go back to put Dr. Wang's slides. Yeah, there you go.
Okay, that was my slide. That's good. So thank you for giving me this opportunity to share with you some Canadian perspective and some early data from our robotic colorectal surgery program at the University of Alberta Hospital in Edmonton. Although after Dr. Aguilar's talk, I feel like we're traveling back in time because we have the SI robot and we do not have the stapler or the vessel sealer. So we are doing robotic surgery, although we are using laparoscopic staplers and laparoscopic ligatures still. We started doing robotic colorectal surgery in November of 2018. So these are some of our team members, and it, like Dr. Aguilar said, that it really takes a village of interested and dedicated people to start and maintain a program like this. To date, we have done about 125 cases robotically. So back in 2018, my partner Ryan Snellgrove and I worked on dry labs and simulations for a few months, and then we went to Sunnyvale to do our hands-on training. And then when we came back, we booked 6 cases in 4 days. And Dr. Fayaz Qureshi from Toronto flew to Edmonton and mentored us for the first 2 days. Following this, we did 18 cases in the first 90 days. And then this is despite the Christmas shutdown period. So by December of 2020, we completed our 100th case. We did record our first, quite a few of our first initial cases to review and critique each other's cases. So next slide, please. So the majority of our cases are low anteriors and APRs, and most are for rectal cancer. We've also done a few total proctocolectomies for ulcerative colitis when we do the colon part laparoscopically and dock the robot for the pelvis only. We tried one right hemicolectomy at the beginning of our learning curve, although we liked the sewing part for the intracorporeal anastomosis, but we found it too tedious since we couldn't change the position of the bed once the SI robot was docked. So we've stuck to the pelvis ever since then. So today I'm just going to share with you some of our results for our low anterior resection and our APR cases. Next slide, please. Before I get into our robot results, though, I wanted to familiarize you with the culture of our hospital, or at the University of Alberta Hospital. So prior to November 2018, the majority of our pelvic cases were done by an open approach. The laparoscopic rectal cancer cases were done in a hybrid fashion where we would mobilize the spinal flexure and the left colon laparoscopically. And then we would do a lower midline or a fantasio incision and use our St. Mark's retractor and do the pelvic dissection that way. Since November 2018, though, as you can see, we now do almost 90% of our cases minimally invasively. This is a huge shift in culture in our hospital and has significantly benefited our patients. Next slide, please. So these are some of the results from our low anterior and APR cases. So I divided our robot cases into quarters, and as you can see, with time, we've gotten faster. And by earlier this year, our median OR times for robotic cases are now comparable to our lap and open cases. Our conversion rate is also lower for the robotic cases. So far, we've only converted one robotic case in our case series, and it was a patient that we had done for Crohn's disease. Next slide, please. Looking at our median length of stay, it's also decreased as time went on, as we got more comfortable discharging these patients earlier. It's 4 days for robotic pelvic cases versus 6 days for lap and 7 days for open. And our readmission rates also are quite remarkable. So that's it for my presentation.
Thank you very much. That really gives insight onto what we can try to aim for here in Canada when we get started. And we'll have some questions for you very shortly. Next, Dr. Caycedo.
Thank you, Marlies. Thanks very much for the opportunity also to present from our group. First, I'm in Kingston, Ontario at Queen's University, and I have to acknowledge that I did not participate in the building of the program, because when I got here less than a year and a half ago, Dr. Sunil Patel and Dr. Hugh McDonald, I think Dr. Patel trained under Dr. Garcia-Aguilar, and they were the ones who built this program. I was fortunate enough to be recruited here and start working on the robot, and pretty much landed on my feet when I came here, and it took about 6 months before I started doing this. If I can get the next slide. So I started in October of last year, and it was a challenging time for reasons that we all know. It was impossible to go to the US to get the program as it was designed. I was supposed to go down, I believe, to Florida, but that could not happen. So the plan changed, and then we started into kind of like a fellowship model, but it was great because I had 2 surgeons that were there pretty much every day, Dr. Patel and Dr. McDonald, and even as of today, the way we do this operation is there is always 2 surgeons. There is one surgeon doing the console, there is one surgeon doing the assist, and then we have different roles for our residents, either a junior resident or a senior resident. I come from a background in which I was doing a lot of laparoscopic surgery and TATME, and we can talk about that experience later on. But definitely, you know, as every technique, everything evolves, and the indications for TATME for me, after being in contact with the robot, have changed, and I think has been a natural evolution. Most of our cases are done for left-sided pathology, especially rectal cancer. We also do complex diverticular disease in this fashion, and I believe even most left-sided cases, I would say at this point, are being done laparoscopically, also to try to maintain competency and try to maintain level proficiency. Can I go to the next one? So there are a few different things, and the one important thing that changed, and these are numbers collected by Dr. Patel and Dr. McDonald, and they go from, the program here started in March 2019. I believe they were done for training, but there was a technical problem with the OR. I think the sterilization unit floated, so they had to stop the program for like 3 months. So they started more or less in June of 2019, and what really changed was completion of minimal invasive approaches. They have a conversion rate of almost 30% of the cases were being converted to open. So the ability to complete these cases in a minimal invasive fashion is what really changed the program and where they actually saw the advantage. Can we see the next one, please? Now, in my own experience, I can tell you that when I was doing TATME, and I still do a significant number of patients with TATME, I can tell, this is almost anecdotal, but I would say about 40% of my patients will go home on day 2. Patients that I do TATME, and we extract the specimen transanally, and you see there is no incisions, but still there is some degree of pain. But what really impresses me is that when we do these cases robotically, probably I would say 60 to 70% of these individuals could go home day 2, and you go and you wonder, after all the resection, everything you've done to these individuals, next day they virtually have no pain. Now, could you achieve the same result laparoscopically? I think you can, and with the enhanced recovery surgery protocols, for sure. And even open, you can still do some of those outcomes and achieve close to those numbers and send patients. Even consider the possibility. I think there are different projects now even considering doing outpatient colectomy, and there is some literature out there for that. But the length of stay changed significantly, and that's what helped this group to actually reach out to the administrators and convince them that there was a significant value. And if I can get the next one, please. As everybody knows, budgets in Canada, having the model that we have, models are divided in silos. So the OR budget has nothing to do with the budget from the ward, and it has nothing to do with the budget in the clinic and things like that. But with the QBP, the quality-based procedures, that model of funding actually has changed some things. And when you have a patient in which the cost is going to be higher in the operative room, but the length of stay and the cost outside of the OR is going to be lower. And then we show in the data, or they show in the data, that the overall cost of the stay was actually lower. Now, this is not factoring in the capital cost of buying the platform for obvious reasons. And that was obtained through a donation. But right now in this hospital, even the administrators don't give any issue, because it's almost, there's no difference for them in terms of cost. What you're going to do, either laparoscopically or you're going to do it robotically. So for us, keeping that volume has not been an issue now, because there is no issue with the cost, knowing that we can send those patients a lot faster than they did. I believe the length of stay was about 7 to 10 days before, and it brought down to almost 4 or 5 days now with the robotic platform in general. Can I have the next one? I think that would have been my last slide. Yeah. Thank you.
Thank you very much, Antonio. So the floor is open for any questions from the audience. So please bring in the questions. I've received a few, so I'll go on ahead and get started. Maybe Dr. Caycedo, to follow up on what you said, how do you choose between what you'll approach by TATME, or if you still do laparoscopy, and by robot?
That's a great question. Yeah, I still do TTME, and I think there is total bias. I can just feel attached to TTME, and after spending so much time doing and investing in learning TTME, it's hard to let it go. We have tried sometimes to do robotics and TTME, but the question is, how do we make this operation more expensive? So maybe it's not the great way to go. The challenge that I see sometimes, with the robot is defining your distal margin. And in those patients in which I think I'm going to have that challenge, perhaps I still could say, I'll do TTME. But like the transition, I think, is not difficult. The transition from TTME to robotics is not difficult. The learning curve is significantly less steep from TTME or laparoscopic surgery, and the ability to see, there's just no comparison. What Dr. Garcia-Aguilar showed in his video, there's just no comparison, and the ability to recognize the planes and do things. And as he pointed out, it's not going to make you a good surgeon if you cannot be a good surgeon and see the planes.
Yeah, thank you so much. Makes sense. Dr. Wang, how did you approach your administration, or how did things get going for you in Alberta? We need some advice on the East Coast here.
Honestly, I think we were in the right place at the right time. So our urology colleagues at the University of Alberta Hospital had been doing robotic prostatectomy for as long as I can remember, but the utilization for the robot was nowhere near 100%. So we were approached and asked if there was any interest in starting robotic colorectal surgery. And around the same time, our ENT colleagues were also learning on the robot as well. So when we actually started doing these cases, we sat down, the three services, and with the booking office, and we came up with a way to share the robot and increase the utilization. And so most times we, certain days are urology days and certain days are general surgery days. But we have shared the robot as well. So ENT often uses it for their transoral stuff for a couple hours in the morning, and then they have a flap to do for the rest of the day. So we do a ileostomy reversal or a small case to start with, and then we roll in the robot whenever it's ready. So we share the robot that way to increase utilization.
That's very helpful, and it's very similar to our current situation. Dr. Caycedo, would you have any other remarks about hints on how to start a program, or any hints, advice on how to sell it to a Canadian administration?
Well, take a look at our soon-to-come paper. I think it's useful for the Canadian experience. I think Sunil Patel has done a great job collecting data and showing how this could be used to approach the administration. But once they see that difference and getting out of the silos, I think they will see the financial benefit for those individuals.
Definitely, and I think some of the data was presented as a poster, so it's quite compelling. A question for you, switching kind of gears back to practical, Dr. Garcia-Aguilar, that I received is, why does anesthesia really need to be part of this team? What's anesthesia's role? You mentioned them as a key part of the team.
Yeah, I mean, I think probably the position is not very different from laparoscopic surgery, but definitely it's different than from open surgery. For example, when we do prostatectomies, the patients are in a steep Trendelenburg position. If you're going to have a lengthy procedure, our procedure, fortunately now they are not that long, but at the beginning of the experience, there were issues with having patients for too long in that position, compartment syndrome, other issues. So I think they need to be part of that. The patient has to be, when I started doing minimal invasive, just keeping the patient on the table was a challenge. We had to have the bean bags, things like that. You had to have, there were a lot of issues that they were related to them. Then the pneumo, peritoneum. I think, for minimally invasive in general, the anesthesiology has to be a good part of the team. Just keeping the patient stable. Morbidly obese patients in the lateral tilt, when you are trying to, for example, mobilize the left colon in an LAR, and you have to have the patient a significant 15 degrees or lateral tilt, you want to be sure that everyone is on board and you're not going to lose a patient from the table. So, I think there are a number of issues that the anesthesiologist needs to be involved. Again, with minimally invasive in general, but I think there are some peculiarities about robotics that, they are special.
That's helpful. Thank you very much. Dr. Caycedo, you mentioned that you're always two staff. So you have a surgeon at the bedside. Dr. Garcia-Aguilar, you have a PA at the bedside. Dr. Wang, how are you doing things?
So we've been doing most of our cases together. Actually, when we first started, to take the learning curve just a little bit, making it easier for Ryan and I, we learned this together, and we did our first few cases together where we would split up the cases. So one person would mobilize the IMA, and then we would switch, and the other person would do the the pelvic dissection posteriorly, and then we would switch again. So we don't get that robot fatigue, because initially, I think when you're just learning, there's so many things that you need to pay attention to, all the buttons, all the hands, and I think just to divide the case into parts, and I think the first few cases we probably maybe did 20 minutes each, and then we would switch and do that. And it took a little longer at first, but I think breaking it down into parts really did help. And to this day, we still, try to be available for each other for most of those days, because we often have new residents coming in, not sure, with even just being the bedside assistant. And then, as I mentioned before, we still use the laparoscopic staplers and laparoscopic ligatures. So especially for the very low pelvic ones, the stapling is quite tricky laparoscopically. And so we still try to help each other out on our cases.
Yeah.
Thank you. I think that's really a cool way of doing it. And it's the first time I've heard of the team splitting up that way. So I like that suggestion. Any other suggestions on this topic?
Yeah, I think it's a good idea that the surgeon spends times at the bedside. And, I have worked in 3 sites, and I have done robotic in 3 institutions. I started at UCSF, I did at City Hope, and then at MSK. I only had PAs at the MSK. In the other places, we have to do some of the bedside work. And it's very good because you need to know how the equipment works. You need to know how to dog and dog. You need to know all the technicalities of the equipment. And I think if you just going to have somebody at the bedside, you're never going to learn. In my case, I was much better at knowing the equipment and how, avoid collisions and glitches and have the arm in the right position with the previous version of the equipment when I was spending time at the bedside than now. Because now everything is given to me. And so, I don't need to pay so much attention. I advise everyone definitely to learn how the equipment works at the bedside. You cannot, start a program without, knowing the hands-on, just docking and all the details.
Thank you. Yes, we'll hear your words kind of ringing in our mind as we are frustrated at the beginning of our learning curve.
Yep.
For Dr. Caycedo and Dr. Wang, how long did it take the OR teams to become agile with the setup and the takedown? Has that improved dramatically?
From the data that I have and the way I see our team functioning, I believe the first 2-3 months were kind of a challenge, but as Dr. Garcia-Aguilar was pointing out before, it is a dedicated nursing. So there is no rotation. There is always the same group of people coming over and over. And that's also one of the reasons why we have these 2 surgeons, because as residents change and rotate, you might have a resident who is really good and he's really good bed assistant, but then that resident is gone. And then you run into the same problem until you get the next resident up to a level that you say, hey, you really got this now. Not only the bed assist, but going to the console. So having the 2 surgeons and having a consistent nursing staff really helps. I think I'll be site dependent, maybe a site will be ready in 1 month or a team will be ready in 3, who knows?
Yeah, we started out with a core group of nurses, and then I think they eventually, like Dr. Garcia said, that eventually add new people in. So I noticed that nursing team training more nurses, so that in case we ran late into the evening a little bit, then the evening nurses were familiar with how to undock the robot or put the robot away. We were also lucky because the urology nurses already were very familiar with the robot. So if we had in the nursing side had any issues, there was someone right next door. So we were lucky that way.
That's excellent. I mean, it's so key to have a consistent trained team whenever possible. And so that's wonderful. Another question, how do we approach patients? You know, we're going to be starting something new, and we sort of feel that we need to divulge that to patients. So when you started your programs and you introduced robotics to the patients, how did you do so and what was their reaction? Maybe Dr. Wang, if you could start with that one.
Sure. Honestly, I think in the Canadian population, I feel that most people don't really know the difference between robotic surgery or the benefits or the differences of robotic surgery. So I usually try to explain to them, you know, that it does give us better visualization. We can be more precise, and you have less pain, and you know, and but I think unlike Dr. Garcia-Aguilar, you can comment on this, that the U.S. patient population is very different. That some of your patients may actually demand colorectal or robotic surgery, whereas the Canadian population, I feel like most people, more so over the years, I feel more people are asking about minimally invasive surgery, but not specifically robotic surgery. We do tell them that this is a new thing. Like when we first started, we said this is a new technique that we're doing, and it's not a new surgery, it's just a new way of approaching the surgery. But we do tell them that it's still us controlling the robot, not the robot doing its own thing, and that because we're starting a new program, we're more careful about following our results, and we keep track of all our data. So we do keep track of every case that we've done so far. We've actually started giving people quality of life questionnaires before and after surgery. And although after you talked earlier this morning, Mary, maybe we should give them the LARS score instead, and follow them that way. But we do try to see if there's a difference in how patients feel, right? The patient's perspective.
Thank you.
Yeah, I think for us it's a little bit the same. We tell the patients minimally invasive, and we don't. I think we always stay away from using the robot as a marketing tool. So in fact, in our consent, for whatever reason, when we consent the patient, we say laparoscopic/robotic right colectomy, laparoscopic/robotic whatever. We consider them, it's a tool. It's a tool to do minimal invasive surgery. We don't distinguish that. We don't see many patients that they come specifically because, you have to do it robotically. They don't ask. They don't even say, we're going to do it open or minimal invasive. If somebody comes with a rectal cancer, they just want to have it done. I think, the more sophisticated patient, yes, I mean, they expect that it's going to be minimal invasive. But we don't get much in terms of, okay, what are you going to use? And, we just consider one tool to do minimal invasive surgery. And that's the way when we represent it in our surgical consent.
I think that in our center, it's similar to what Dr. Garcia-Aguilar is describing. One, we consent as robotic/laparoscopic possible open, because we always tell them there is a small possibility of opening. And we never present the robot as like, this is it. We present the robot as, we have an advanced laparoscopic platform that we could use, and we'll book your case that way. However, if for whatever reason that day something changes and we cannot use the robot, we still do it laparoscopically, and nothing is really different than what we consented the patient for. We haven't had a particular case in which a patient is coming demanding, oh, I want it robotically. If you mention the robot, the odd patient maybe get excited and probably know something about it, but would not be like, make sure it is robotic. I think most patients just say, I want everything to go right. Whatever you choose, sure, I'll go with it.
Yeah.
Yeah, I think that really sounds like our patients, and I think our patients are more similar than we had expected. But that's also great advice that on the consent we will list everything, because we never know how the day will go. Yeah. How has robot access or robot use changed at all over COVID? And free for anybody who would like to remark on that. Has it helped? Has access been limited more? Has there been any changes for those of us who are thinking to launch during COVID now?
Well, if I can come in on this one, I started training for robotics during COVID. I got into doing robotics during COVID, and nothing has changed. And what has changed is volumes in terms of ups and downs, when there has been lockdowns, when there has been cancellations, but there has never been oh, we cannot use the robot. There has been things such as, go out of the room because a protocol for intubation requires you to be outside. Do this thing different because when you're gonna deflate the patient, you have to do this. But we treat it as a laparoscopic thing. Nothing changes because there is COVID. If they let us do surgery, in fact, the only surgeries that for us have not really suffered is cancer. Everything else has. And even, bad benign conditions, which is bad for patients, but I'm pretty sure everybody has experienced the same type of constrictions because of COVID. And the requirements, I would say, from administrators and public health officials change almost every day. But for us, there has been no particular impact on using the robot and COVID-19.
That's great to hear.
Yeah, I agree with that. I think sometimes we're limited by number of patients we can admit after a certain OR day because of hospital beds. And so, we are at a point in our learning curve where we're trying to do two cases in one day. And so, but we're limited by that because of beds. But right now, as you guys know, Alberta is really bad in terms of our COVID numbers. So as of next week, we're only allowed to do priority A cancers. And so even colon cancers can't get done. So fortunately, rectal cancer after neoadjuvant treatment is considered a priority A cancer. So that's probably all we'll be doing, none of the other cancers, which is very unfortunate.
Dr. Aguilar, any impact of COVID for you guys?
No, what you was saying before, at the beginning, we were all scared about the transmission of the virus and all the extra precautions in the operating room with the pneumoperitoneum, deflation. But just the same in laparoscopy, our volume went down clearly last year, 2020. But like everywhere else, there were no endoscopy, there were no diagnosis of cancers. But now we are probably back to full speed this year. People are starting to just seek, medical attention again. I think New York was really a big shutdown in March, April, May of last year. But then we started to go back again. And I think we are now seeing the same volume that we did before. And fortunately, our hospital is a specific cancer center. We don't have an emergency unit. So the only patients that we see with COVID are our own patient population who, when they get COVID, they come to us. But the COVID population in our hospital is very low, so we can continue treating cancer.
That's great. That's great. I think, like you said, you paid for it in 2020, and that's enough. So,
yeah.
I know you do a lot of watch and wait, or you've taught us a lot about watch and wait. And thankfully, we don't have a lot of local regrowth. But when we do, those cases are tough. I find the fibrosis tough. I find the space between the tumor and the sphincter shrinks. What do you think about that, and with the robotic approach, and how are you handling those cases?
Well, I think, there can be some more fibrosis and maybe a little bit more challenging. This morning, I was doing a TME in a patient who cannot receive neoadjuvant therapy, and I was telling my fellow that I like the rectum a little bit cooked. I don't like it raw. A little bit of radiation therapy. If it's not too far out after the radiation, usually makes the dissection not much more difficult. In fact, it makes it a little bit easier. It makes the planes a little bit more compact, like the case I was showing. Otherwise, the planes are sometimes too loose. It can be difficult. I think, we had got in patients that they had, I mean, in general, the regrowth that we observe in watch and wait, if we are following them closely, the regrowth, fortunately, they have been small. But yeah, in cases that they are advanced for whatever the reason and you see them late, the planes can be quite difficult to dissect. And they are difficult to dissect no matter how you do it. You know, again, the advantage of the robot compared to other technologies is that you're going to see the planes better. You know, when cases get beyond the normal anatomical planes, they can get quite complicated. And then if you need to get outside of the mesorectal plane, you know, we do lateral pelvic lymph node dissections and we do extensive surgeries. It can be challenging. I mean, just for experts. I mean, sometimes we have done tumors that they have infiltrated the lateral compartment directly, not just you know, internal ileal lymph node, and getting you know, those cases getting into the right plane is complex. But I think it's still more complex to do it open than the robotically. We didn't do a good job with the lateral pelvic compartment when we were doing open surgery, doing a lateral pelvic lymph node dissection. Definitely minimally invasive, laparoscopic or robotically is much easier. So, you know, in some of the tumors, you need to get outside the anatomical plane, the robot still helps. Now we have done, not infrequently, I mean, in not a case that we do every day, rectal cancer infiltrating, for example, the prostate. We have done a en bloc resection using robotics, combined with a neurologist who can get to do the prostatectomy, get to the front, get to the level of the rectum, and then just we do our prostatectomy. So I think when you have a team of people who they are used to work with the instrument, you can do complex cases, you know, you can do cases that go beyond the normal anatomical mesorectal planes. So I think just getting teams of experts can make the surgery feasible also. I don't know if that answers your question, but you know.
No, absolutely, it does. It does. Dr. Wang, Dr. Caycedo, any final thoughts?
Probably the last thing that I would say is for our residents, with our model of having always a surgeon available, we have created a role in which we always have a junior and a senior resident. And I would say 90% of our residents are interested in the robot. Not all of them want to do, obviously, colorectal surgery, but our last 3 chiefs from last year, 2 of which went for colorectal fellowships in the States. When they left, the 2 ones that went for those left with about 30 cases each at the console. So we have a role for them. We have the dual console, as Dr. Garcia-Aguilar was pointing out. And I think that's of significant value to have those residents. More juniors, we only let them on the bedside, and they let them watch on the console, but not really get into it. But all our seniors, if they're interested, which I would say is 90% of them, they will have. And now, even though it's not a mandatory, it's not part of the Royal College curriculum, but we have modified, we are on the works to modify our curriculum to get that kind of as a comprehensive rotation for our residents to get at least that exposure, because we firmly think that this is the future they're going to be exposed to, and if they don't have at least a bit of knowledge, it's going to be more challenging the same way it has been for us.
That's really encouraging to hear, because I think a lot of our programs here are very highly focused on producing good residents, and especially our senior residents. I think they highly value our colorectal cases. So it's really nice to hear that you've been able to integrate them with a meaningful experience, it sounds. So that's awesome. Hopefully
and we tell them to go on the simulator as many hours as they want. That's what happened to me. COVID time, I moved to Kingston alone. My family stayed behind. I just went countless hours on the simulator, and it was like video gaming or something. So it was fun and time well spent, I guess.
I'm sure you're a master technician already, but I'm sure it's fun. Dr. Wang.
We're still trying to get our hospital administration to fund a console. So unfortunately, we don't have the teaching console at our hospital to allow our residents to do that, but we do, our senior residents do get them to come on the console a little bit and try to play around with the console part a little bit, but we are still working on that piece. But I just wanted to say for starting out a new program, I think everything that's already been said, but having another partner to learn together, I think it is very key. And then also just to let your hospital OR know you're going to run late. Those first few cases, you're just going to run late. I think one of our APR cases at the beginning took 9 hours, which we prepared and we knew, and then no one is stressed and no one is right. So we're learning a new technique, and then just basically have people around you that can help you, even if they're from a different specialty. I think that really helps too.
Yeah, talking about simulators, one of the things that we shouldn't forget is that the robots usually are not used 24 hours a day, and when I started, there were no simulators, so the only way to put your hands in the instrument, we'll get it in the console, and the arms after the OR has finished, just have somebody help you set with some of the instruments, and then just practice and practice and practice. Just with there was this kind of round, I remember the round thing with the the rubber thing, and you pass the. There were a number of drills that you could do with the robot in extra hours. And also, even today, I emphasize that the trainees use a dry model with the real robot to practice suturing, because it's very, you can simulate suturing in the simulator, but I think like nothing like just suturing real. So I think that's also an opportunity for training. Just use the equipment after hours and then just practice and practice and practice. Usually the reps or whatever company, is helping with equipment, they usually are available to, help setting the equipment to practice after hours. So that's an opportunity.
Yeah, that's what we did. After the kids went to bed, we went to the OR and just practiced.
Yeah, I have spent Saturdays doing that. When I started, Saturday morning, just, I have it set it up and then just work and work and work.
Wow. That's really awesome and practical and motivating. We're really about to embark on a program, and so I will hear you when I'm being lazy. So thank you for your honesty and for being practical. I really enjoyed this session. I'm really grateful that I got to be amongst the three of you, each with your expertise and experience. Thank you, Dr. Garcia-Aguilar, for joining us from New York. It's really an honor. We really look up to you, all of us here in Canada, and we follow your work. So it's an honor to have you amongst us. And Dr. Caycedo, you just moved and you adopted a new technology and are presenting about it, and it's pretty impressive. And Dr. Wang, it sounds like you really blew this off the floor and gave such practical advice. I'm really honored to have been with all three of you, and I hope the audience enjoyed it. Thank you to CSF for allowing this symposium, and to Dr. Maclean. And thank you very much to Minogue, who put us together and organized this for us with CSF. So if there's no other further comments, thank you to everybody and have a great evening.
Thanks, everyone. Good night. A pleasure to be here. Thanks a lot. Bye.